Excellent. All right. So we should be live on Facebook, and I will get started. So good morning, good evening, good afternoon to everyone who has joined us. I am Dr. Akwi Asambang. I'm an interventional gastroenterologist. I am the co-founder and board president of the Pan-African Organization for Health Education and Research. I am excited to be here this morning. Happy to see you all. Happy to have you join us. We have such a very, very rich topic to discuss today. And the format is, as always, the whole point is for this to be an educational session. We do have a professional. We have a urologist with us today. And our urologist is Dr. Chalwe Mumba. The questions we have were received from you, the audience, and feel free to use our chat for those who are in the webinar. For those who are live streaming watching this live on Facebook, feel free to drop a question in the comment, and depending on time, we'll try to address all those questions. So the focus today is men's health, but it is such a diverse and rich topic. So we are going to discuss just about everything you can think of, starting from the basics about the penis, all the way to sexual dysfunction, erectile dysfunction, prostate cancer, BPH. I mean, there's so much. And we're just super excited to have Dr. Mumba, who is the first female urologist in Zambia. Yes, I had to throw that in there.
I know.
So we're excited to have her today. And I'm just going to introduce our POHER scholar. He also has a rich bio, and I have to read this. So Wicgoal Chatiem, who is a co-founder of TEDI, and he is a medical student in Malaysia pursuing his MBBS with a keen eye on obstetrics and gynecology in his final program. He's particularly fascinated about the state of South Sudanese women's reproductive health literacy. His research interest is in fistula and gynecological complications in the developing world. He is very well accomplished. He is a community health and social work development practitioner and has been involved in community health and social work led programs for over 4 years. He has several academic credentials in both public health and the social work arena. He's been trained in Kenya and Malaysia respectively. Chani holds a diploma in public health at Kenya's Regional Institute, as well as a professional certificate in community development and social work at St. Paul University in Kenya. So we have a super accomplished POHER scholar, Wicgoal Chatiem, who's going to serve as our moderator, and the conversation is going to be between them. You, the audience, like I said, please feel free to drop your questions in the chat box. Dr. Mumba, on behalf of POHER, thank you for taking the time out of your busy schedule, and thank you so much for spending this weekend with us. I will now step aside, and let's get this conversation going. To the audience, this is your floor. Ask your questions. Don't hold back. You have a urologist with you right now. This is your time. Take advantage of this moment. Thank you, Dr. Mumba. Chani, over to you.
Thank you, Dr. Asambang, for such a kind introduction. And I also like to thank the Pan-African Organization for Education and Research for giving me this opportunity to moderate this session on men's health today. So our topic for today is a conversation with urologists. So we'll be mainly focusing on erectile dysfunction and prostate cancer. And our main speaker for today's POHER education series is Dr. Chalwe Mumba. Dr. Chalwe Mumba is coming from a very interesting background. She's the first female urologist in Zambia. So for those of you on the webinar and all of you watching us live on our Facebook page, please sit back and relax. It's going to be interesting 2 hours to learn from one of the best in the field. Without taking over your time, Dr. Mumba, can you please go ahead and tell us about yourself? Please walk us through your own personal journey. Why urology? Challenges you have encountered along the way, and what has inspired you to become one of Zambia's first female urologists?
Hey, thank you so much. Thank you so much. It's my second time being on the POHER educational series, so I'm pretty excited. As I've been introduced, I'm a urologist. I deal with the genitourinary system of both men and women, as well as the reproductive system of men. My day-to-day schedule is quite busy. We have outpatient clinics. Then I do surgery once or twice a week, depending on how the lists are going. And it's very interesting because urology is both a hospital specialty as well as a, outpatient kind of specialty. So you get to have a very wide variety and wide range of conditions and patients. And it really gives me an opportunity to stay in touch with the community, stay in touch with what's going on around, because I meet so many people from babies all the way up to grandfathers and grandmothers. So it's a very involving, immersive kind of subspecialty. Anything else? What else did you ask me? Why urology? Primarily, it's like I mentioned, the variety and diversity that's in urology. It keeps you engaged and allows you to help a wide range of patients, and just helps you stay in touch with the community and practice medicine from an outpatient perspective, clinic perspective, all the way to surgery, to hospital urology, to awareness programs like this. So it's a very engaging kind of subspecialty.
Wow. So that's very rich backgrounds, and what you accomplished is really great. I hope a lot of people find inspiration on your career path and what you are trying to accomplish. I know it must have not been easy, being a female urologist, even the way it's on is like, more male-dominated career. So what were some of your challenges you faced along the way?
The challenges were more on the academics. It's really involving. You really have to be dedicated, because I did a fellowship as well with the College of Surgeons of Eastern, Central, and Southern Africa. So I was doing that at about the same time that I was getting my MMed in urology. That's my master's qualification. So it was quite challenging in terms of academics, because you have to put in a lot. It doesn't come easy. So you really have to put in quite a lot. And it requires a lot of support from your family. I had my children while I was in training. So, I really needed a lot of support from extended family, from my immediate from my husband. So it's really a holistic kind of approach to going along this journey. Of course, from the community, I didn't get a lot of pushback, but I do have, I have had patients who are not comfortable being seen by a young female doctor. So those are kind of challenges you have to overcome, and understand the background that people are coming from, and be able to navigate that and assure them of professionalism, and that they'll be treated well, regardless of their gender, regardless of my gender, and their background. My job here is to treat you, and to treat you professionally. So that's how I've navigated through those kind of challenges.
Wow. You mentioned academic challenges and some of the other setback you get along the way. So what are your comments on mentorship? Or people have read about your journey. So I'm sure there will be a lot of young girls out there, boys that would want to walk on your shoes. So what would you say on mentorship regard to someone aspiring to be a urologist? How important is that?
I think mentorship, I myself had both mentors and sponsors throughout my journey, and they were very pivotal in leading to my success. It was really a team effort. My consultants were always very supportive. My senior registrars, who I now work with as my head of department, it's really been a journey really of carrying one another, and they'll be able to point out your weaknesses and your strengths and say, look, you need to focus more on this, you need to, and they'll push you. So you can't do it. It's not a one-man show. When there are opportunities, someone who's your sponsor will be able to say, look, I think you'd be good for this. Why don't you take this? You know, so you can't walk this journey alone. You need to identify, though we didn't sit down with my mentors, they had no choice in the matter. They were there while I was there. So we ended up in this mentor, mentee, teacher, student kind of relationship. And I think it contributed to my success, because then I had a benchmark to kind of look at and say, oh, this is how you walk this path. And they'll share their challenges with me, and some of the shortcuts, like you don't need to make these mistakes. We've made these mistakes before. So you can't do it alone. And that's one thing I don't even hide from anyone. You must have your mentors, your teachers. Those are important, even if they're not necessarily in your field exactly. Like some of my mentors were general surgeons. I had 4 mentors within the field of urology who I could approach for different needs. So, it's something you have to look at very broadly and understand that you can't do it alone. You need a support system. You need some guidance.
Guidance. Wow, that's very interesting. And here at POHER, there's we're working with our POHER mentors. So they're working day and night to get young medical students and junior doctors to to thrive in the field, including on how they can choose a career path. Thank you so much for shedding light on that. So let's dive into our conversation. So for our audience out there, so today we are talking about the penis and something called prostate gland. It's something. It's an organ in a male reproductive system. So before we dive into question or getting your question you sent to us out to Dr. Mumba. So Dr. Mumba, why don't you give us basic about the penis? So focusing on the structure, like what is it made of, and before we go to what could go wrong with it, also give us some elaborate on how an erection is happening, a penile erection is happening. Then those will give us typical information on what we are going to dive in. Thank you.
Okay, so like I mentioned, I deal with the male reproductive system as part of my day-to-day job. So to get us started, I'll answer, I think, the elephant in the room. Number one, the penis is not a bone. Let's start from there, because that's a very common misconception that the penis is a bone, and all sorts of misconceptions. The structure of the penis is actually quite interesting. It's made up of spongy tissue, tissue that can absorb, okay, and expand. So it's expansile. It can expand and deflate, okay? So it makes the basis of penile function. The other important, I think, aspect of the anatomy of the penis would be the urinary function, apart from the sexual function, the urinary function. The male urethra, that is the tube that passes urine from the inside of the body to the outside, is also housed within the penis, right? So the penis will have both the genital urinary function and the sexual function, okay? And these are housed all in one organ. The urethra is housed at what you would call the bottom of the penis. If you're looking from the top, it would be the bottom. That's where the urethra passes. And that usually doesn't take part in erection. The most important tissue for erection would be the top part. If you're looking from the top, the two structures at the top of the penis, okay? So these are known as the cavernosal bodies, the corpora cavernosa, basically spongy tissue that fills with blood and allows an erection to take place. Since we've already gone into that, I always say before discussing erectile dysfunction, it's important to understand erectile function and the different components that lead to a successful erection, or tumescence as we call it, okay? So there's different factors, but the overall, the first thing that I like to emphasize is that one needs to be in a general state of health. What is that? That is free of physical, mental, and other illnesses, and you must be in a condition of general health, number one. Okay, and then when we look at it more focused, a more focused look at it, erection is basically made up of blood coming from circulation going into these spongy tissues that I described. And once the blood goes there, it should be able to stay there. Okay, so the two important components. The blood should actually go there, reach the penis, and it should be able to stay in the penis long enough for someone to have satisfactory sexual activity. Now, satisfactory sexual activity is very subjective. So I won't go too much into that, but the basic physiology behind it would be you need enough blood at about a pressure of very similar to your normal blood pressure, actually, about 100.
That's interesting. Yeah. All right. Yeah. So that's thank you for
that's basic.
shedding more light on the basic of it. So I'm sure now our audience are will be able to get the flow of the conversation. So then what is the erectile dysfunction? Like, what happened that the penis would go out of wax and it doesn't sustain that doesn't sustain the erection. So what's going wrong? What is the erectile dysfunction? Thank you. Go on.
So like I said, one of the key things to note about erectile function is that one needs to have certain things intact. Okay, so there's different along the erection pathway. There's many different steps. It's not as simple as it may be sounding right now. So there's many different steps, and a dysfunction in any of these steps can lead to erectile dysfunction. If we're putting it simply, I would say you have the penile factors, and then you have the general health factors, and maybe we could even put mental factors, okay, if we're putting it generally speaking. So when you're looking at the penile factors, obviously you need a penis, an intact penis. I say this because in some conditions, like in this part of Africa, we have a lot of sickle cell disease. Sicklers are prone to what's known as priapism. And a child will have priapism on and off throughout their childhood. And if it's not treated adequately, it will lead to fibrosis of the penile tissue. So which means they will most likely have erectile dysfunction because their penis is fibrotic and therefore it's not elastic enough to stretch and fill with blood. So that's one factor. Number two, you're looking at the circulatory system. You need an intact circulatory system in order to bring blood to the penis, right? So in people who have diabetes, for example, diabetes mellitus, these are people who would have microvascular, or well, their vessels will not be healthy, okay? So then that's an impediment. And then you've got where the blood is coming from, the pump, the actual pump, the heart. So people with cardiovascular disease, high blood pressure, for example, and other comorbidities which would impede on the adequate function of the cardiovascular system will lead to erectile dysfunction. So you find that there's different levels of impediment, as it were. One other thing I almost forgot, the nervous system. You need your nervous system to be intact because where the signal's coming from. So patients who've had spinal cord injuries, for example, some patients with spinal cord injuries, some patients with strokes are unable to sustain or unable to obtain erections because the pathway has been disturbed. So you need to look at it very globally to understand at which level the erection is being affected. In patients with prostate cancer, for example, you'll find that it's a nerve impairment, okay, where the prostate cancer invades directly into the pelvic nerves that are responsible for erection. So that's another way that the pathway, the erection pathway is disturbed. Please clarify priapism, Dr. Mumba. Okay, so priapism is an unwanted sustained erection. It can be caused by many different things. We won't get too much into that, but it's basically an erection that is unwanted and it's sustained, cannot be brought down on its own. Typically for more than 4 hours, we consider that priapism. Okay, so different things can cause priapism. Sickle cell, like I've already started that topic, can cause priapism as a type of sickle cell crisis, for example. And these children will end up with the vessels being clogged, the outlets being clogged. So the blood that went into the penis is unable to come out. For adults, there's other mechanisms of priapism, but that's the basic principle. It's basically an unwanted sustained erection. I think I answered that.
Yeah, you did. Thank you. Thank you, Dr. Mumba. You also included on the question the causes. Also looking at it at the comorbid condition that are associated with the erectile dysfunction. So, and also the factors that are involved. So that was so clear. It's not so clear, and I've got the audience. Understood it. So, how common is the problem, and at what age, do men get erectile dysfunction?
So that's an interesting question. There's been studies, there was one actually done right here in my hometown that showed that the age of erectile dysfunction is actually going lower. Traditionally, erectile dysfunction is expected in the older male with the
older you get, yes.
Yes. However, recent studies and recent data is starting to show that our patients with erectile dysfunction are getting younger and younger. And in fact, erectile dysfunction can be a surrogate or a precursor, so to speak, of cardiovascular health. So you find that in patients who are presenting primarily, in their 40s with erectile dysfunction, you do a cardiac workup, you find that these are patients at high risk. So the age is getting younger. Traditionally, we expect, the older men who are probably undergoing androgen, not deprivation, but whose androgens are getting lower naturally. And that's kind of changing now.
Wow, that's interesting because like you mentioned, so that's a very worrying situation. Like when you're having like how young can this man be? So there are a lot of docs men mentioning out there that it could be a sign of a more serious problem, like you said, a cardiac problem. So if it happened on a man younger than 40 years, so could that mean that these people are probably having or at higher risk of developing a cardiac problem in the future?
Look, I can't say definitively, but there is data indicating that it's, there is some association, okay? With younger men who come with erectile dysfunction, I'll always do a full workup, including hormone profile, because it could be so many different at different levels. Yes, so we do a full workup, we do a full neurological exam, we do a full hormone profile, and of course you have to do your mental assessment as well, because psychogenic erectile dysfunction is also common.
Wow, that's interesting. So, what are the signs of the erectile dysfunction, and how or when do you know when to see a doctor?
Generally, I like to say, look, as soon as something is wrong, see a doctor. I think there's a delay. Can you hear me well?
Yeah, I can hear you. There's a bit of a delay, but I can hear you. Can hear you well. Carry on.
Okay.
Yeah.
Okay. All right. In terms of signs of erectile dysfunction, it's quite obvious from the description, erectile dysfunction. So this is someone who's unable to either obtain an erection or sustain an erection for meaningful sexual activity. That's, you know.
Doctor. Yeah. All right. Thank you for that clarification. And now let's talk about erectile dysfunction and marital relationship. You know, how strained can this be on a couple or partners on this sexual health and their relationship in general?
So I'm not really a relationship expert, but as you might expect, it will obviously cause a significant strain, which is why we always like to get the psychiatrist, psychologist input when treating these patients. You treat them holistically while we do the full workup, the physical workup, the examination, etc. You make sure that you bring in the mental workup as well.
Yeah. Wow. So it's a multidisciplinary approach, like also looking at what could be, you know, a mental health cause or the psychogenic cause of it. So that's interesting. Right now, our world is going through pandemic, and in Africa, people are still behind on vaccination campaign. So, there any evidence-based link that erectile dysfunction and COVID vaccine, for example? So, what is already out there?
I'm finding that difficult to answer because there's just not enough data to make an informed conclusion on it. What I have seen in some of the data is that the testes are a reservoir for the COVID virus. So that was quite interesting for me, and it kind of supports getting the vaccine to avoid, but I really can't make a very informed comment on it.
All right, Dr. Mumba, that's yeah, it's a very hard question to answer, as you know, we're still learning a lot thing about COVID, and like you said, so it could be the reverse, the other way when you're saying, so testes can be a reservoir for COVID. So, you know, getting your chances of getting COVID in the first place by getting yourself vaccinated, you know, it's the best way to protect yourself. So don't have a lot of, there's not a lot of information out there to justify that. Thank you so much for shedding light on that. So now with access to psychogenics, you know, stimulant like watching phones, stuff like that, could that induce an erectile dysfunction in younger people, for example?
So the good news is when you understand the basics, the physiology of erection, you'll see that what are the things that can disturb. Porn, masturbation are not necessarily, you know, affecting any stage in the erectile pathway. Unless, of course, someone is mentally disturbed by their own masturbation and by watching porn, you know, with porn addiction and things like that, maybe. But on its own, pornography, masturbation there's no data to support that those would negatively affect one's erectile function. So I would say so far there's not sufficient evidence for me to, you know, to say masturbation affects erectile function, because it's you know, it's not like you have a certain number of erections per lifetime, and if you finish them, then you're done.
All right.
It's not like a bank account. You can't deplete it.
Yeah, that's interesting. So thank you for answering that. So, you know, given all these factors that are involved in how an erectile dysfunction can happen, so what is the risk reduction strategies, or how can we prevent it?
Sorry, I didn't get your question.
Dr. Mumba, can you hear me now?
Yes.
All right. So I was saying, given the, you know, all the risk factors you mentioned and all the causes, so what are the risk reducing strategy we can use to, you know, to prevent erectile dysfunction?
My take-home message in terms of erectile dysfunction, it's a factor of health. So I would suggest that general health, measures to keep yourself generally healthy, number one. We all know the NCDs are related to weight, they're related to, diet. So all those the most basic health promotion factors. I don't think there's anything in particular I could point at to say, do this to prevent erectile dysfunction. I would encourage like those with high blood pressure, for example, to take their medications. Those with diabetes to make sure they have adequate glycemic control, because those are the factors that lead to erectile dysfunction that is difficult to treat, because, the cause is, it's almost, permanent damage that has been done.
Yes, yeah. Thank you for shedding light on that. So for the audience, like Dr. Mumba, clearly stated that, so that's not exactly what you could be told to reduce your risk, but it's very important to look out on your health, on your general health, because like she mentioned already, all of these are kind of connected to the ED, especially the vascular diseases and like diabetes and hypertension. Thank you, Dr. Mumba, for that. And is there any tests, like tests to be performed to diagnose the ED?
Yes, there are. First of all, there's erectile function scores that we use, that we administer to patients. There's also, I don't know if you can identify with the Holter monitoring ECGs for the heart. We also have an equivalent for the penis, and the patient will sleep with this. Yes,
well, that's
monitor.
Interesting. That's interesting.
So we do a Holter monitor of the erections throughout a 24-hour period. So those are some of the tests that we do. Apart from tests, we'll also do blood tests, check your cholesterol level, your lipidemic levels, your glycemic levels, the general things. Check liver function as well, and a general basic exam.
Right, thank you. So what are the available treatment options for the ED, and any side effect, if any?
So number one, like I've been emphasizing, number one would be, if you're hypertensive, do not ignore it. Take your medication, do your checkups, make sure that your blood pressure is under control. If you're diabetic, the same. Okay, those are primarily some of the main things you can do. Once we do have erectile dysfunction, we do give, what is the non-medical term? The family of Viagra. These are phosphodiesterase. The simpler way. I'm trying to find the simpler way. Well, basically, they encourage the vessels to dilate. Okay, the vessels dilate, so we give these drugs that allow your vessels to dilate and relax and allow the blood to flow. But this is based on the fact that you have healthy vessels which can respond to this medication. Because if the vessels are completely destroyed, then we can't do much. With patients who've had, for example, something traumatic, or have had penile trauma, or have had priapism, and the penile tissue itself is damaged, we do penile implants. These penile implants can be the rigid ones, the semi-rigid. There's so many different options, and these can at least allow someone to have a satisfactory sex life. So there's, from the medical all the way up to the surgical options for treatment of erectile dysfunction.
All right, so so that seems there's a lot of options out there to treat ED, like mentioned by Dr. Mumba. So so what could be, you mentioned getting medication that would allow your penis to or rather your penile blood vessel to relax, so that they fill up with blood, because that blood that sustain an erection. So if you're taking such kind of medication, so what could be the worst side effect from that?
One of the side effects would actually be a sustained erection that doesn't go down. So you may end up with priapism. And that's why we actually warn patients before, and it's always best to take these drugs under prescription and under guidance of your doctor, so that if anything does happen, we can assist you before it goes very far.
Yeah, talking in priapism in adults, so is that a medical emergency, or if?
Oh yes,
because you could
it's
imagine a sustained
emergency.
erection for 4 hours. So how soon they
Very
can they
painful.
go to the doctor? And it's an emergency, you say they should see a doctor, like as long as they're sustaining an erection that's lasting like 2 to 3 hours. That could be
I think at 1 hour. At 1 hour, it's already not normal, because the average sexual act is documented to be 4 minutes, but I know everyone will argue with me. 4 minutes is accepted as a normal duration. So by the time, by the time it's an unwanted erection for longer than an hour, 2 hours, 3 hours, then we have a problem.
All right, so so we are almost done with our first topic, which is the erectile dysfunction. So to wrap this up, and then we go to the prostate cancer question. So, can you tell us the difference between decreased libido, which is maybe for laymen or for non-medical terms, someone having decreased sex drive? So how does that relate to ED, or are they like connected, or they're different?
So as entities, they're different, but they can be related. A person can have both a decreased libido and erectile dysfunction, or one of and not the other. Okay. A decreased sex drive, again, can be hormonal or organic, or it can be caused by an actual organic cause, or it could be psychogenic as well. So it's very important to do a good assessment, and also to assess your patient for erectile function or dysfunction if they do have a low sex drive, or a low libido. Yes. So they can occur concurrently or independent of each other.
Yeah. All right. So that brings an end to the question we have for ED. So now let's switch gear to prostate cancer. This is increasingly a very worrying condition among our population. So before we go into that, asking you questions that are sent by our audience. So can you tell us briefly what is the prostate gland? So again, like you give us basic about the penis, so its structure and a bit of its function.
Okay, so prostate gland. This November, I'm talking a lot about the prostate. I'm starting to dream of prostates. So the prostate gland is peculiar to men. Only men have a prostate gland, and it's found at the base of the bladder. So if you were to imagine your head to be the bladder, the prostate gland sits right at the neck. Okay, and when it, as a man grows, the prostate gland also grows. It becomes a problem. It becomes a problem when it causes constriction, and now urine can't get out of the bladder. Okay. Functions of the prostate gland, many different functions. One of the functions would be to provide nourishment for the semen, nourishment for the sperm that's found in semen. Yes. It makes a component, significant component of the semen. So that's basic function. So it takes place in sexual, it takes part in sexual function.
All right, thank you for giving us the basics. So, and now let's dive into some of the questions we have for the cancer itself. So, how common is prostate cancer in the Zambian scenario? So, if you can shed some light on that. And
so prostate cancer is actually slowly becoming one of my personal areas of interest because the numbers are just increasing, year in, year out. It's the second cancer affecting the Zambian population nationally. Not men, but the population of Zambia. This is a second, it's even surpassed breast cancer, So prostate cancer is a leading cancer. It's number 2 in the country right now. And I'm not sure about statistics around the world, but I do know it's the second leading cause in some areas of cancer deaths in men after, I think cancers like lung cancer. It is a significant health concern for us, and it's worth discussing over and over again.
Right, so we're getting some questions through our inbox here. Can one's prostate gland be removed and still maintain the sexual function? Or
yes, if you remember how we described erectile function, it's completely independent, right? So prostate gland produces some of the content of the seminal fluid, the semen. So semen is made up of other components. So the prostate secretions are only one of the components. Okay, yeah. So one's erectile function should not be affected by having a prostate gland removed, except in the case of cancer, which is a different topic altogether, for discussion, yeah.
All right, so is there any association or relationship between men's sexual activity and the risk of developing a prostate cancer? And before you answer that, so what are the risk factors for developing the prostate cancer? Some of the risk factors.
So prostate cancer is an interesting factor, and the biggest risk is age. Okay, the biggest risk factor is age. So as a man grows older, there has been shown to be a positive relationship between one's age and one's risk of developing prostate cancer. Environmental factors do not play a big role in the development of prostate cancer. Sexual activity has been implicated to be prostatoprotective. This is some old studies. Yeah, some old studies that have been done. And I'm always asked this question, but the basic principle is the biggest risk factors for prostate cancer would be age, number 1. And there has been a high association between prostate cancer and men of Black origin. So you find that Black African Americans, Afro-Caribbean, people of Afro-Caribbean descent do have higher rates of prostate cancer.
All right.
Sorry, I had a bit of noise just now. Sorry about that.
That's okay. We can hear you.
It should quiet down in a minute.
Yes.
Okay.
So what about benign prostatic hyperplasia? And then along with that, is it the same with the prostate cancer? Like, can it lead to prostate cancer, or what are the differences?
Okay, so sorry, my son needed something. So BPH, like the name implies, is benign, meaning it cannot lead to prostate cancer. Typically, if you look at the structure of the prostate, the BPH, the benign prostatic hyperplasia, will be in a different area of the prostate, and cancer is usually in a different area. So they're not mutually exclusive or inclusive. There's been no correlation between the two.
All right. So, what about a screening guideline out there to diagnose the prostate cancer, or rather, when should men do screening for it in case they're having like a future risk to develop the cancer?
So there's been quite a bit of discussion in the world of urology about screening programs for prostate cancer. What makes a good screening program? Lots of big studies have been done to say maybe we don't need to screen for prostate cancer, maybe we do. So there's a lot of discussion ongoing. But in my part of the world, prostate cancer is getting more awareness. And so a general guidance is men above 45. And for those who are at higher risk, that is those who have first-degree relatives that succumb to prostate cancer, we're going as low as 40 to start screening and, you know, for prostate cancer.
All right. So what about the timeline? There any like agreed specific timeline on when you should, you know, do screening again? What's out there?
So generally, I would advise a well-manned checkup. You know, once a year, go see your doctor, have your prostate examined, have your BP checked. That's for healthy men with no comorbidities. And then for those who may be at higher risk, maybe twice a year, every 6 months, just because you're at, you know, at a higher risk. And like I mentioned, people with higher risk are those who have a first-degree relative that is a father or a brother who died of prostate cancer. So those are at higher risk, and we would encourage those to take more interest in, you know, in an assessment.
Getting themselves checked. All right. So there's been a question sent by one of the audience. They're asking, do like you mentioned, I would say maybe it's you know, it's more of the case for many sub-Saharan African countries. There's definitely like a surge in Zambia for, you know, for the cases of prostatic cancer. So it should be, you know, a concern, and like you said, it's one of the, you know, one of the most common cancer in men after lung cancer. So some people are trying out a lot of things to, you know, apparently like in conventional medicine, still one of the challenges trying to treat cancer. Some people are trying out pounded pumpkin seeds, you know, in the hope that it can help them prevent the cancer. There are any evidence based on that, and what can you say?
So I think one of the things that makes one a good doctor living in a community of people is I don't like to rubbish people's beliefs right off, especially if they're not harmful. So what I like to say to homeopathic treatments and natural remedies is try and do your own research. As far as I have seen, I have not seen any natural compounds that can prevent prostate cancer. Okay, simply because of the physiology behind the development of cancer. Okay, at a molecular level and, you know, at a cellular level, there are so many different factors that are happening that lead to development of cancer, such that, you know, the exogenous or environmental factors that cause, you know, the prostate cancer are very few, which therefore implies that environmental factors to try and, you know, treat the prostate cancer or prevent it would also be equally few, simply because of the type of cancer it is and how it develops. So I would not be, you know, safe to say, no, there's certain natural elements, which, no. However, if you want to take certain things to boost your general health, like I said, that's well and good, you know. I think I mentioned in one of my other talks some time back that a zinc-rich diet is good for prostate health. And people are always asking me, but why did you say that? And I say, look, it's general health, general men's health, you know, just like we take multivitamins, but it's not going to prevent the cancer. It's not going to treat the prostate cancer. It's just a general, you know, and I wouldn't prescribe it, you know, as a doctor. I wouldn't be out there prescribing it as a prophylaxis or anything like that.
Prophylaxis or anything like that. All right. Wow, that's interesting. So, people try out a lot of things so to kind of boost their health, immune system and stuff like that. So like you said, you wouldn't encourage someone to, to take something that is not proven of having a benefit. And to the people out there, maybe you are hearing this. So like Dr. Mumba said clearly, she couldn't recommend it or, give it to you as a definitive cure for cancer. So if you do have a risk for cancer and you think it's, it's going to help you, you have to seek a professional help and don't take that as a, as a yes for it. So Dr. Mumba, our discussion is, almost to be wrap up. Someone is commenting here, motherhood doesn't stop for Zoom. We can hear Junior, at the background. So
he wants to say hi.
We're almost getting over. Yeah, we're almost over. So given that, so what are the conventional treatment for prostate cancer? So looking at the chemo, radiations, and the surgical option for it.
Okay.
And if any, what are the complications or rather side effects?
Okay. So prostate cancer is a very heterogeneous type of disease. What do I mean by that? It's not a homogeneous disease where you say you diagnosed with prostate cancer, therefore this will happen, therefore this will happen. Prostate cancer is very heterogeneous, meaning that different people will present differently, and we tailor make our treatment methods directly to a specific patient. So we can have 2 patients with prostate cancer, and it doesn't guarantee that we will treat both of them exactly the same. That's one thing that I really need to put out there. Even if you have a diagnosis of prostate cancer, your cousin has a diagnosis of prostate cancer, your friend from next door has prostate cancer, it doesn't mean that you're all on the same treatment. Okay. In terms of how we manage prostate cancer, there's a wide range. So depending on the clinical presentation, some patients we will not treat, okay? And we will not treat with the intention of treating in the future, or we will not treat with the intention of not treating ever. Okay, and these are decisions that we make with the patient. We give them the options and we give that as an option. Okay, so I think we had a chat with the oncologist last year, and she said as well that even doing nothing is a form of management. Okay, doing nothing is an option, but only with joint decision making with the patient. And then, of course, we have the different therapies for curative intent, for palliative, different for every patient. It will be different. In terms of cure, you have the general options. You can have a surgical approach. Under surgery, it can be open surgery. It can be minimally invasive, if I put it that way. It can be robotic. It can be laparoscopic. But the basis will be the same. It's to remove the cancer surgically and have tumor-free margins. That is, not leave any of the cancer behind. In some cases, you may remove the lymph nodes as well. Okay. Then in terms of non-surgical, we have the chemotherapy, the radiotherapy, and these are used in different combinations. Prostate cancer is a peculiar cancer because we also have endocrine therapy. This is where we use hormones and modulate those hormones to address, the different symptoms that the cancer would come with. So broadly speaking, those are the different options that we have, and we use them in different combinations depending on the situation.
Wow. Thank you so much, Dr. Mumba. This has been so insightful. So this is our last question for our discussion today. But before you give your final comment, I want you to give us your opinion, rather your comment on the notion of men's health in Africa. So what do you think about African men, masculine toxicity, let me call it like that, or you say it, masculine norms in relation to their health outcome? Because, men, natural kind of thing, they are, physically strong, and they have, such low, like emotional careless. and if in terms of health, sometimes they even like they discourage seeking medical help before something can be done about it. They go more often when it's too late, and on top of that, they are the gender that are I would say indulging in high risk activity like maybe alcohol or smoking. All of these things have have a lot of general factors to men's health. So what do you think? What do you think about that? Yeah.
So the data is pretty clear that men's health-seeking behavior is quite poor, and this is why I like to say that I think in the treatment and management of men's health, of cancers, it's a family kind of approach, because we all live with men in our families, in our communities, and the community approach and the family approach, I find, is the most helpful way to overcome this challenge. Because it's a challenge. Different subgroups of people have different challenges. So this is just one of the challenges. If you look at, the global South, for example, you'll find that in some communities, the male gendered roles would include breadwinning, would include, going out there to kind of hustle for the family. So we can't ask those same people, as they're doing that, we can't ask them to come in for regular screening, and it's just not feasible in rural communities and far out communities. So what do? We can go to them, we can use a community-based approach, and it's important to understand what we're dealing with. So to say it's toxic, it's neither here. I would say rather understand it as a challenge and find ways around it. How to approach them, how to bring in this particular group of people.
All right, so that making it look as a disparity, and like in that context. So before we wrap it up, so in that regard, putting it as a as a challenge, you said. So what are your key recommendations on how men's health should be attuned to the wider better health care system or outcomes, like let's say, for example, in Zambia and across the continent?
I would say the same approach we have to other public health challenges. Identify the problem. I think there was a study out of Kenya which was looking at, I think, men's perception of prostate cancer, and some of the complaints that came out were it takes too much time, or there's young attendants who are not professionals. So you listen to the community, listen to where their problem is, and reach them where they're at. In Zambia, we have community, what are they called? Community health assistants, something like that. And these are key because they live in those communities. If you're looking at a rural community, look at the village headmen. That's a very good starting point. If you're looking at the urban communities, find these men where they commune. You have to find a way in and get the message out. This educational program, like the one we're doing right now, for our urban dwelling men, they will be listening in. So these are, they seem like small steps, but this is one way to overcome that and improve our men's health outcomes.
Wow. So that's definitely the way to go about it, like you said, considering any other, health challenge. So, and that, that means, a lot of resources also to be, geared to this, and more importantly, the education part of it. Thank you for shedding light on that. Before we wrap up, there are some few questions that are here on the chat. Someone is asking, prostate cancer treatment, is a cash cow to the medical world. Like, I would assume this person means, people are being drained out of money on cancer treatment, for example, take prostate cancer. So, and that is also particular to where you are. in Zambia. How can this be affordable and equally be not that expensive for the patient? As also like an increasingly growing concern.
Yeah. Prostate cancer, like any other cancer, is expensive to treat. Why? Because in fact, in my opinion, I feel like the surgical management of prostate cancer is cheaper. The curative, you may find it's cheaper than the long-term androgen deprivation therapy, the chemos. These are drugs that we don't have much control over because they're manufactured where they're manufactured, and you have to buy them at the cost they're sold at. There's not much we can do about it. So cancer treatment world over is expensive. I think as Africans, we should invest in developing more funding for healthcare. I think that's the ultimate solution. Funding for healthcare, systemic, overhaul of systems. That's the only way we can go around it, because cancer treatment is expensive. That's a fact. I don't even think our African doctors are making a killing of prostate cancer. It's actually a thorn in our side to try and treat our brothers, our fathers, our uncles. It's a difficult cancer to treat, especially when you can't cure this person because of resources. So I would say, yeah, it's a challenge, and we need to look into how we can, overcome this challenge.
Thank you, Dr. Mumba. So the answer is let's invest in our healthcare system, do on research and development, and it's not easy. This is even in the developed world as well. People don't find a cure for cancer, and it's very difficult. So someone is saying, do you have an encouraging word for female fraternity to take up urology, people that are watching you live? So what can you tell them? And then this will be the last question, so it has been asked here in the chat. And then maybe you can make your final remark, and that will be all, Dr. Mumba. Thank you.
Okay, so females wanting to join urology. Worldwide, actually, there has been a jump in female urologists in training, even in developed countries, even in the global north. So I would say this is the time, ladies. It does allow you a bit of flexibility in that in certain healthcare systems, you're able to choose if you're going to do outpatient urology only, if you're going to do hospital urology only, if you're going to go into research. So there's so many career paths. It really is enjoyable, and the science is beautiful. And you get to be known as a penis doctor. So I think it's I think it's something I really enjoy. There's a lot of humor, and you really learn to balance out living with diverse people in the community and having a diverse job description. So I would say go for it. If you've got the stamina to get through the training, just do it. Find yourself a good training site, a good mentor, and go for it.
Wow. So ladies out there, that is from one of the best we have. I would say it's in the continent, and go up and take up your aspiration in urology. Thank you so much, Dr. Mumba, for your time. This has been so insightful. I'll give it over to Dr. Asambeng. Thank you.
Thank you, thank you, thank you. I don't even know how many thank yous I could say. Dr. Mumba she's been just absolutely amazing for us as a resource. She's an amazing resource for the continent. We have a lot of questions that we have not answered. There's questions about herbal boosters. I mean, there's just a lot of questions. And, we're
on herbal boosters, I will say that someone actually did a test on some of the herbal boosters we get in Zambia, and they found Viagra in it. So just heads up. Yes, so heads up. They pound a lot of stuff, make it look very traditional, but the active ingredients, they go to the pharmacy and put in some Viagra. So FYI, in case anyone was wondering.
Oh, wow. That's actually very interesting. No, so hopefully that answers that question, because then now it would make you wonder if, some of these other things that are being quoted as herbal, this, that, and the other may actually have another, manufactured ingredient. That's really interesting. Yeah, thank you to the person who brought that question up. Really appreciate that response. Seems like that's going to be another whole new topic to discuss. So once again, on behalf of POHER, and that question, I keep saying on behalf of POHER and saying we're wrapping up, but that was such an impactful question, the last one about females, because the added comment, the one about females taking up urology, because the added comment is basic, and this was from, a fellow colleague, a male. It says men are in obstetrics and gynecology, so we need enough women in urology. So if you're, and I think, just imagine, as Dr. Mumba said, the highlight is you're going to be called a penis doctor. So, take it on, right? If this is something you want to do not be discouraged. I think in anything you'd love to do, there's going to be barriers, there's going to be challenges, there's, going to be stigma associated with what you want to do. But if that's where your heart is, if that's where your passion is, then reach out to someone who's doing this. Hi. Reach out to someone who wants to do this. I think that's a big sign that we need to hurry up and let mama get home and do her motherly duties. So on behalf of POHER, absolutely grateful. Dr. Mumba is extremely busy as a surgeon, as a urologist. We are so grateful she's taken the time out of our busy schedule to be here with us. She's taken the time out of her family just to spend with us. She's addressed some of the questions. We know you guys have a lot, and we'll end by saying, please, please, please speak to your healthcare provider. Do not hold back. The question about, male masculinity, being strong, etc., does not mean you don't take care of yourself. So think of yourself, take care of yourself. By taking care of yourself, you directly taking care of your family. So on behalf of POHER, thank you, Dr. Mumba. Thank you to our moderator, POHER Scholar Chatiem. Truly appreciate the session. We look forward to having you again. I feel like we'll need to have a single section on erectile dysfunction, a single section on sexual health, a single section on prostate cancer. So watch out for my WhatsApp message next year. So on behalf of POHER, thank you. To those in the webinar, thank you for your questions. To those watching us live on Facebook, thank you for your participation and engagement. Once again, good morning, good afternoon, good evening. Everyone have a fantastic day. Signing off. Thank you.